Hi, this is Junaid with another series, Machine Learning in Healthcare, a Journal Club. This is a series designed to actually highlight some of the papers that have clinical impact or will have clinical impact as far as machine learning in healthcare goes. As usual, my emphasis will be in stroke and neurology. So let's go ahead and start this. The paper is Machine Learning for Detecting Early Infarction in Acute Ischemic Stroke with Non-Contrast Enhanced CT. As usual, disclosures include non-FDA approved discussions, and this is for education purposes only. So this is the paper that was actually published in Radiology in January 28, 2020. This comes from Woo Q, who's the main author from Calgary, Canada, which is one of the best places for machine learning in general, and of course machine learning in healthcare. The paper discusses the presence and, more importantly, the extent of the infarcted brain tissue. The purpose is to automate and quantify the extent of the brain infarcted tissue. What they did was that they actually took data of 257 patients that came in the Korean stroke registry with an M1 stroke. M1 stroke basically is very obvious choice, because if you are trying to convince people that this thing works, you need to either go head to head with aspect scores, which is actually semi-quantification, and this one would be more so fully quantifying the extent of the infarcted tissue. Then they took the non-contrast CT scan, and the selection criteria was that it should be within 6 hours of symptom onset. And the other criteria was to actually get the MRI within 1 hour of the CAT scan. And therefore, that MRI will be pre-treatment, number one. And number two, they also manually contoured all the volume on the MRI DWI. And therefore, they were able to actually get an accurate volume at gold standard baseline to compare when the machine learning goes through. They had 157 patients that were draining invalidation, 130 of them were in the training data, and about 27 of them were in the validation. And the testing was done on 100 patients. Results were interesting, that clearly that non-contrast CT scan was done within 48 minutes, and the MRI was done within 38 minutes of that CT scan. There was significant correlation. The mean difference was only 11 ml, which is pretty darn good. This is the algorithm. The major machine learning technique that is used is segmentation. First you strip the skull, then you tilt, smooth, etc., and then you actually randomly force them and then create a segmented scan. So examples were very astounding. They use exactly the two levels, preganglionic and ganglionic levels, as we use in aspect scores as well, and they publish these beautiful examples. So if you see one on the right over here, you can see that this is the DWI lesion, and then this is the CT scan, which actually was able to get this infarcted volume pretty accurately. And if you can see, it is slightly visible that over here you can see early ischemic changes, but with the machine learning, of course, you can actually see all the way around where these ischemic changes have been. Similarly, on this area, you can see much more clearly. This is the preganglionic slice. Second patient is more interesting. As you can see, the DWI is able to do this and pick it up. But to be honest with you, if I was looking at this CAT scan, I wouldn't have picked it up, either on this scan either. So over here, this is very interesting to see that if I'm going through the machine learning perspective, this could be very easy. And if the patient is coming in, let's say, with a UTI, and you're thinking this is recrudescence of an old stroke, this would really help in your decision for thrombolytics in these patients. Similarly, if you go to the second patient over here, you can see there's a large, more than 1/3 territory of the stroke. And if this patient did show up within the time frame, but if you look at the CAT scan, I mean, over here it's more visible that it's more than 1/3 of the territory, and I would be very careful in giving TPA to this patient. However, with the machine learning, you can actually see that it's a bit of more of a volume, and giving TPA on this patient would actually potentially be harmful as compared to be helpful. Another similar example on this side, again, on the CAT scan, it's very hard to see. You can see in retrospect, always hindsight is 20/20, but if you are looking this in an acute stroke call, it's going to be very hard to see the difference in these things and then pick it up and then going from there. What was interesting in this image was that this looks like a chronic ischemic changes over here, and it didn't pick it up as chronic ischemic changes here, which was very interesting to me because it was hard to, in my opinion at least, to design machine learning software to say. One of the key things that they suggested is that you actually have to give them the hemisphere, and that's what we're going to come into the limitations. Another example over here, as you can see, clearly was not picking up the old chronic infarct, which was again very interesting. And clearly in this example, I mean, this CT scan, it's just potentially, in my opinion, impossible for me to pick up a stroke on this. So patient selection so the clinical benefits are abound as I was going through this. I mean, risk of thrombolysis, thrombectomy, risk of reperfusion injury, and then sometimes it will also dictate what the blood pressure goals would be post-intervention, post-thrombolytics in these patients. And if you are not doing a TPA or intervention, does the patient needs ICU monitoring? Because if you knew that this is a very big stroke from the very beginning, because some of these things look smaller in the first, but actually this can tell you this is not that small, it's actually going to be huge, should the patient be monitored in the ICU? Or even the patient needs to be transferred to a neuro ICU under neurosurgery and may need basically a hemicraniectomy. So these things are important questions for clinical decision making, and this study will help us do that. One of the key things that I am always worried about, and sometimes I have to wait, in my opinion, for no good reason, if I had this technology in my hands, is to either start anticoagulation, because this might be a new embolic infarct, and if I haven't given TPA or did thrombectomy because it's too large or too small, whatever the case may be, what I'm trying to do is assess my risk of initiating an anticoagulation therapy and when should it be started, and there could be a thrombus in the heart where this original clot came from. So this would aid in that clinical decision making of initiation, resumption, and holding of anticoagulation. The limitations are significant in this study. The cutoff volume they used was 70 ml, which is basically used for any of the thrombectomy trials, which is great, but at the end of the day, I think they should not have limited themselves for 70 ml, and we should have lower thresholds as well to see how good it performs at lower thresholds. The reference standard was used MRI as DWI, and DWI is technically reversible. We sometimes use a DWI and flare mismatch to actually give TPA. That is actually the wake-up stroke trial. So is it really the right option to choose? I don't think so. I think a flare would have been better, but anyways. CTA hypoattenuation degree again can be reversible too. So early ischemic changes on the CAT scan can sometimes be reversible, and we have seen that actually in clinical, at least in our clinical practice, that if you give the TPA in a very early ischemic changes, as a matter of fact, even the guidelines approve it, that if you have very early ischemic changes, you should consider TPA. Again, the chronic infarct, leukocytosis, partial volume affected regions close to CSF are the limitations, and then per the writer, the machine learning software was not as good on those spots. Again, these over time can be improved with, again, that's the real beauty of machine learning. It can improve by itself with continuous data and correction of that data and validation of that data. So in conclusion, machine learning is promising in identifying and quantifying infarction. More studies are needed to implement it in clinical studies. And of course, all stroke patients should be taken, not just M1. And I just thought of one more is potentially if we could use this with a flare versus then initial infarct. And also a 24-hour CAT scan should be included at the end to see if it was actually matches post-treatment as well. And lastly, one of the quirks that I had from the very beginning is that what if we were able to get initial CAT scans at 2.5 millimeter mm? How different would it be, and how good it would be to actually get these volumes pre-treatment be quantified? Again, these are things that people need to study more, and I'm grateful for these people to actually do this study. Again, future direction would be 2.5 mm thickness, change the threshold to at least 50, and include flare. I'm really grateful for these people to actually not only publish the study, but also put the whole code at GitHub for free. So if you go on this website at GitHub, they have the whole Python code for the complete machine learning algorithm that they used. Again, this is much applauded because now we can actually go ahead and see the study and replicate it and then see how accurate it is. And this is something that misses in machine learning altogether, and especially in healthcare. So I'm, again, very grateful for the whole team at Calgary to not only publish this paper, but also make it available as an open source for all to see and learn. A few announcements. This is going to be now officially available as a podcast, and then I have also started it as a blog. Again, this would be easier for people to subscribe, share, visit, and etc. So I would be very grateful if you subscribe to my YouTube channel and shared it. Thank you so much.